Buenos días, a nombre de la Facultad de Odontología y de nuestra directora, la doctora Elba, Leyva, Huerta, les damos la más cordial bienvenida a este último día de transmisión del ciclo de conferencias COVID-19. Hoy, 12 de junio del 2020, tenemos la participación de tres grandes ponentes, el doctor Joseph Carrese, el doctor Tomás Bautista y finalmente el doctor Honorable. Hoy vamos a dar introducción a la presentación del doctor Carrese. Les platico que por motivos de la transmisión y de la complejidad, la transmisión será en idioma inglés y esperamos que en una semana después ya podamos tener la transmisión con subtítulos y que será compartida igual por los medios de la facultad, por Facebook y por YouTube. Me permito dar la introducción y la bienvenida al doctor Carrese. Welcome, Dr. Joseph Carrese. We are grateful for your effort for being here this morning as a lecturer of this online event. We know that you have a huge amount of work, but you give the time to share with the Latin America dentists about this bioétics team. So let me introduce Joseph Carrese to the audience. I will give the lecture of your resume and in Spanish. Les presento al doctor Carrese. El doctor Carrese es profesor de medicina de la Facultad de Medicina de Johns Hopkins y es director de la Facultad del Instituto de Bioética de Johns Hopkins Perman. La beca del doctor Carrese se centra en la ética clínica, la profesionalidad con un interés particular en la educación médica, examinando cuestiones éticas en el contexto de la diversidad cultural y la consulta ética clínica. Los artículos del doctor Carrese han sido publicados en importantes revistas médicas y de bioética. Ha sido profesor visitante en varias instituciones médicas, académicas, y ha sido invitado a hablar como speaker en muchas reuniones nacionales e internacionales. El doctor Carrese forma parte de la Junta Directiva de la Sociedad Estadounidense de Bioética y Humanidades entre el 2012 y el 2015, y en el 2012 el doctor Carrese fue miembro fundador de la Junta de Academia de Profesionalismo en Atención Médica y fue presidente de la Junta Directiva de APH del 2013 al 2015. El doctor Carrese es miembro del Centro Hastings. Para quien no lo conoce, es un centro especializado en bioética, ética, que trabaja diferentes temas sociales. Es muy importante, si ahí tienen la oportunidad de visitar el sitio web de este Centro Hastings, es muy importante. El doctor Carrese es presidente del Comité de Ética del Centro Médico Johns Hopkins Bay y es presidente de la Junta de Revisión Institucional de la Escuela de Medicina de Johns Hopkins. El doctor Carrese es médico de atención primaria y atiende pacientes en la Clínica de Medicina Interna General en el campus del Centro Médico Johns Hopkins Bayview. El doctor Carrese se graduó en el Williams College y en la Universidad de Buffalo de Medicina. Completó un programa de beca de excelencia de clínicos Robert Hood Johnson en la Universidad de Washington en Seattle, donde estudió ética médica y antropología. El doctor Carrese se unió a la Facultad de Medicina de Johns Hopkins en 1994. Thank you, Dr. Carrese. Please, let's begin with your presentation.
Hola, buenos dias, good morning to you all. I'd like to thank Dr. Pablo Cruz and the Dean at UNAM, Dr. Leyva Huerta, for inviting me to speak with you today. It's a great pleasure and honor for me to present at your conference. I'm just going to take a moment to share my screen so you can see the slides. So I'm going to start by making a few introductory comments and then share with you the plan for how we'll spend this session. But I first wanted to say that and acknowledge that we're all experiencing major challenges at this time. Because of the coronavirus pandemic, many things have changed, and we are being asked to lead our personal and professional lives very differently. Healthcare systems and institutions, and those of us who work in healthcare, are all under stress and having to make difficult choices about what to do. It is at a time like this, when we are making difficult decisions and tough choices, that we must think about and rely on our knowledge of ethics. Ethics is about doing the right thing, doing what ought to be done in any given circumstance. It involves being aware of our fundamental ethical and professional obligations and duties, and the underlying principles associated with those obligations and duties. Ethics includes the process of thoughtful, careful deliberation when core obligations compete with each other, and it ultimately involves making decisions that we can justify based on careful thinking and analysis. My presentation about ethics issues and considerations in the era of COVID-19 is intended to share with you a framework for organizing and thinking about these issues. The hope is that this session will increase your awareness and knowledge of these ethics issues and will help you be a better dentist, a better healthcare professional. As you can see at the bottom of this slide, several of my colleagues at the Berman Institute of Bioethics at Johns Hopkins have contributed to the ideas and information I will present. So I want to acknowledge their contributions and thank them. Let's see, I'm having trouble advancing the slide. I don't know, Mario, if you can help me advance the slide.
You should click in the middle of the slide and then you go with the space bar. Okay.
Thank you, sorry. So here's the plan for the session. I'll spend about 20 minutes or so presenting the outline of the ethics framework. And then we'll spend some time on cases. We'll do 2 cases that relate to dental practitioners as individuals, and then 2 cases that relate to the practice setting and the clinic, for example, where the dentists and their staff work. And then after that, we'll open it up for commentary and discussion with a student and 3 professors who've been selected to address each of the cases. And then at the end, hopefully there'll be some time to open it up to the listeners and the audience to ask some questions. So you can see on this slide our framework that we've developed to discuss clinical ethics issues associated with the coronavirus pandemic. And this framework, of course, was developed in the context of the Johns Hopkins health system, which is primarily focused on medical care, not dentistry. So there may be a few issues that may be unfamiliar or might not directly apply to dental practice, but I think most of the issues to be presented are relevant and important to your field. The framework is organized into 2 categories. On the left, the first set of issues are associated with practitioners, so dentists and other healthcare workers themselves. And the second set of issues on the right are associated with the practice setting, so the systems involved and the places where we do our work. A few points to make about this framework. Some of the issues, for example, resource allocation is included in both categories because it applies to both categories. The second point is that any given patient's case may involve issues from both categories, as we'll see when we discuss the cases. And of course, the list of issues in this framework are not intended to be exhaustive or encyclopedic. We couldn't cover all of the issues, but we think this is a good start and that some of the more important and common issues that we are all encountering and wrestling with right now are included. So in the next several slides, I'll go over each of these issues in a little bit more detail, and I will present and briefly discuss several cases that illustrate these issues and their associated obligations. So the first issue for practitioners listed was resource allocation. And we've certainly heard about this on news reports and in the newspaper. And one example of resource allocation for practitioners is the availability of personal protective equipment. And we've seen in several countries, for example, Italy and the United States, several cities in the United States, there have been shortages of N95 masks. And one of the problems that shortage presents for healthcare workers is that they have to wear the masks longer than is usually intended. And then the effectiveness of the filtration system in the mask starts to break down and putting healthcare workers at risk. So some of the questions that we ask about resource allocation shortages is, why are there shortages? Whose responsibility is that? And then when a shortage exists, how do we decide who gets the short supply? Who gets a PPE when there's a shortage, and based on what principles and priorities? The next issue has to do with rights and responsibilities of practitioners during the pandemic. And certainly one of the most important responsibilities is the duty to care, our responsibility to provide care to patients, even if it means putting ourselves at risk, putting ourselves in harm's way. Some of the cases that we'll be discussing raise this issue. In our healthcare system, we've also been encountering the phenomenon of redeployment, so that nurses usually do one thing, but they're being asked to do something else. Doctors typically work in this setting, but they're being asked to work with COVID patients. So many people in the healthcare system are being stretched and asked to do activities and engage in healthcare that is beyond their usual scope of practice, and that is, of course, stressful and difficult. We're asked to answer the question, what's essential and what isn't in terms of healthcare workers' responsibilities and activities. So as dentists, what is essential and for you to be doing, and who among you are more essential than others in terms of your skill set and your capabilities, and how do we decide that? And then finally, the notion of at a time during a pandemic, when there's increased burden, increased work, increased risk, how do we allocate that and distribute that fairly among the people involved? How do we determine what fair division of labor is, fair division of risk? And do we take into account personal circumstances and personal vulnerabilities? So should the healthcare condition of a dentist or another healthcare worker, or of the people they live with, their family members, be taken into consideration when determining what duties they will be assigned? Certainly, the notion of moral distress and stigma and racial bias have come up during the pandemic. Moral distress comes up in the form of anxiety and distress about safety, about the suffering that we're seeing, about the uncertainty that we're encountering and having to make decisions under. And this, the safety and suffering and uncertainty can involve ourselves as practitioners and healthcare professionals. It can involve concerns about our family, and of course, and primarily it involves concerns about our patients and their family members. One of the most stressful things that we've encountered at the hospital in Baltimore, where I work, is patients who are at the end of life and who will die of the coronavirus, who can't be visited by their family members because of policies that are preventing visitation due to risk of transmitting the virus. So, you know, it's terrible for people to die alone without family members, but that's what's happening right now, and that's causing a lot of suffering, both by family members and staff members having to witness that. And then there's the issue of stigma and racial bias, which is with us always. It certainly comes up in a variety of contexts in the United States, but in this particular situation with this pandemic, we've seen it come up in the following way: that Asian healthcare professionals have been targeted by patients and family members as someone that they don't want taking care of them because they think somehow that they are at higher risk of having the coronavirus. And, you know, unfortunately, some of that is perpetuated by what our political leaders have said and the language they've used, like calling this the Wuhan virus or the Chinese virus instead of the coronavirus. So I think certainly in the United States, that's something that we've encountered. We have to be on the lookout for that. We have to have a game plan for responding to it. If one of my colleagues is being attacked in that manner, I will step forward and say something and be their ally, and we will make an effort to re-educate patients. But certainly bigotry based on bias and ignorance is not something that can be tolerated. And then issues that have come up for us related to individual care as compared to the public health have been very challenging. Usually, me as a primary care doctor, as a physician, I'm sure for all of you as dentists, taking care of your patients, the focus is on the individual patient. It's on their well-being and their interests. But COVID-19 has forced us to change our priorities and put public health concerns and considerations above the interest of individual patients. So the individual patient's interests are subordinated to public health concerns, and making that adjustment has been challenging and it's been difficult. And it's, for me and my colleagues, it's been a little bit disorienting. What are the consequences of delaying care for individual patients because of public health concerns? Will their conditions get worse? Will they experience injury or morbidity that is irreversible? So those are some of the concerns that involve this switch from a focus on individual care primarily to now focusing primarily on public health. And the other way the public health priority has affected at least medical education, and I'm sure dental education, is it's changed education entirely. The education of professional students and trainees like residents and interns and fellows, I'm sure in dentistry, but also in medicine, nursing, social work, has been interrupted due to priority on public health concerns. And now we're encountering decisions about when to allow students and residents back into their clinical rotations to work with patients, because after all, you can't be a good dentist, you can't be a good doctor, nurse, or social worker if you're not actually working with patients. That's a major part of your training. So there's a trade-off between essential learning on the one hand, and then safety for all involved, the students, their patients on the other hand. And certainly one thing that we've done with education in the last few months is remote learning, but there certainly are trade-offs and limitations to remote learning versus in-person learning, especially when it comes to patient care. Next, I wanted to switch to issues for practice. And one of the major issues that comes up with practice is deciding in this coronavirus pandemic, what is essential and what can wait, what is non-essential, and how do we decide that? And what is the threshold for what can wait and what can't wait? In our clinic, and I'm sure in your clinics, you're deciding about what's urgent and what needs to be seen, and what's more routine and can wait another few weeks or maybe even a couple of months. But at some point, if routine care is delayed too long and compromised too much, there's the worry that problems, sometimes irreversible problems, will develop. So underlying these questions is the tension between the core ethical principles of beneficence, or benefiting our patients, and the principle of non-maleficence, which is our obligation to protect patients and avoid harming them. And by delaying the provision of care that we would under normal circumstances provide, we are attempting to avoid the harm of infection with COVID-19. But at the same time, we are preventing the benefit of usual care. And so the question is, what is the right balance there? So for example, routine dental care, for example, dental cleanings, probably can wait a few months. But what about treatment of a cavity or an abscess or other conditions that you're much more familiar with than I am, that may get worse and more serious if not treated sooner than later? And those are the issues that you're all grappling with right now. Another issue that comes up in the context of practice, so the clinics and the institutions and the staff that we work with and the patients, is the notion of telemedicine and remote visits. So this involves only audio connection or audio and video connection, but that technology is not available to all of our patients. It's certainly not available to my older patients. When the technology is available, there actually are some benefits that we maybe hadn't anticipated. So when I see one of my patients in their home, I get to see their home environment. Maybe I get to see the circumstances that they live in. Maybe meet some of their family members who are important to them. One of the things I do as a primary care doctor is make sure that the list of medicines that I have and the medicines that they are taking at home are the same. We call that medicine reconciliation. When they're at home and they can walk to the kitchen and get their medicine bottle, that process is much more accurate and much more efficient than when they're in the office and they don't have the bottle with them and all they can do is describe the color of the pill. So that's a benefit. And for some patients who are older and maybe more frail and have difficulty getting back and forth to the hospital campus, a remote visit, a video visit, a phone visit is more convenient and less time and cost is involved for them. The problems, of course, is you can't do a physical examination. You cannot do your dental cleaning procedures or other procedures. And of course, if it's just a phone call, you can't see the patient and you lose information by not being able to see them. So there are pros and cons to remote visits, but at the end of the day, we all need to be seeing our patients eventually in order to take optimal care of them. Another issue that comes up for practice is the issue of health disparities and stigma and bias for patients. So we talked earlier about stigma and bias for providers, for dental practitioners, for physicians and nurses, but now this is about patients. And certainly this is more likely to happen for our vulnerable populations. In the United States, historically disadvantaged populations like the African-American community, our immigrant populations, which can be better or worse depending on the administration, the president who's in power, and now is a rough time for immigrant populations in the United States. Prisoner populations are, of course, vulnerable. And vulnerable populations typically lack resources. They may lack health insurance. The nature of their employment may increase their risk. So many of the patients who I take care of who have less money, who have less resources, can't afford to work from home. Their job requires them to be at a business cleaning the office or providing childcare or working at a factory. And they don't have the option of sitting in their living room at home on their computer. And many people can't afford not to go to work. If they don't go to work, they can't pay their rent, they can't buy food. And for all of those reasons, vulnerable populations are at risk for poor outcomes, higher rates of infection, hospitalization, and death. So I think as healthcare professionals, we have an obligation to be aware of all this and do what we can to help our patients and our communities that are more vulnerable. Certainly, we've been dealing with the issue of resource allocation during scarcity. So in the hospital, that means what will we do if we run out of ventilators, if we run out of blood products, medications, staffing? We have faced some of those decisions with certain medications that are being used to treat coronavirus, like remdesivir. If we have to make these decisions, what values and principles should we base them on? And usually that includes trying to save the most lives and the most life years, and something called the life cycle principle, which means if you've lived till your 80s, maybe the person who's in their 30s with 2 young children should get priority. And then whatever the principles are, a major objective is to be transparent and as fair as possible about this, and to try to avoid coming up with a system of decision-making and principles that compounds the disadvantage for populations who have already been disadvantaged historically. So taking their circumstances and their situation into account. And then finally, for ethical issues for practice, there's the challenge of counseling during uncertainty. I've had a patient recently who was having difficulty walking, and we wanted to get some additional imaging of his spinal cord to see if there was a problem there, but that meant him coming to the hospital and being exposed to that environment and to the radiology staff. And this was an older man who had a number of medical conditions that would put him at risk, including diabetes. So the tension there was between getting a test done that would provide information that might help make a diagnosis versus not having him come because of the risk of infection, but then the underlying condition might get worse. And all of that decision is being made in the context of uncertainty. We don't know what's going to happen in the future for his condition, how quickly it will progress. We don't know how great the risk is for him to come to the hospital. So we're doing our best using clinical judgment and experience. And the worry, of course, is that we might get it wrong. And that is a source of worry and distress. So next, I'd like to just briefly present 4 cases and then make a few remarks about them. And then we'll ask our student and our 3 professors to make comments about each of these cases. So Dr. Pablo Cruz and I came up with these cases together. The first is a 6-year-old boy who has signs and symptoms of a tooth abscess. The resident asked the mother why she took so long to come to the clinic and get attention for the dental problem. It's taken several days. The mother explains that her father was in the hospital with COVID-19 pneumonia and ended up dying, and so they couldn't come earlier. That raised concerns to the resident, but both the mother and the child have no symptoms. Nonetheless, the resident tells his professor that he refuses to attend to the patient. So there's a number of issues that this case raises. Certainly one is the importance of the duty to care, the duty to serve, which is a really important ethical and professional obligation. There's the professional obligation of putting our patients' interests above our own, and that relates to our sense of professionalism and the public's trust in us doing the right thing. Certainly questions come up about whether or not the treatment of this condition can be delayed or treated with medications that would be less risky than doing a procedure. And I invite our commentator to comment on that. I think one question here is, what's the standard of care? What would we normally do? And is there justification for departing from it? This patient doesn't have any symptoms, but that doesn't mean, or the patient doesn't have symptoms, the mother doesn't have symptoms, but that doesn't mean they're not infected. But certainly the risk is probably lower because they don't have symptoms. Could testing be done to clarify that issue? But if it's positive, wouldn't we still have to take care of him? And then I think finally a big issue here is what will the professor do? Does it matter in response to the resident refusing to care for the patient? Does it matter that other residents and staff will be watching her example? What does she do because she's a role model? So that's an important aspect of this case. The second case is a 65-year-old professor who has diabetes and is under treatment. He's very concerned about the potential exposure to COVID-19 because it represents an increased risk to his health care, or his health rather, compared to his younger colleagues who don't have diabetes. He is especially concerned about his clinical roles where he will see patients, and he requests to be reassigned to other activities with minimal to no in-person patient contact. So I think some of the same issues that we just mentioned in case one come up here. Certainly the duty to care and serve comes up, but with a bit of a twist. Does it apply equally to everyone? Does everybody have the same duty to care regardless of circumstances? Or should individual risk factors be taken into consideration? In this case, a chronic disease. What if the dentist has a condition that requires them to be on a medication that causes immunosuppression? What about maybe the dentist is healthy, but there's family members at home who have chronic diseases or are immunocompromised? So with those considerations or those factors taken into account, should a request like this be accommodated? And does it matter what the staffing capabilities are? If you have a lot of staff, maybe it's easier to accommodate. If you're short of staff, then it's harder. And if accommodating this request means increasing the burden and the risk to other colleagues, what about their welfare and their rights? So these are difficult questions without easy answers, but I think we have the best chance of making the right decision, or at least a better decision, if we carefully consider all of the facts and the issues raised. So now I want to turn briefly to two cases that relate to dental practice itself, the systems we work in, the spaces we work in, the staff that we work with. This is a 17-year-old female who has an intellectual disability and severe tooth pain who's seeking urgent attention, but who does not have an appointment. She has a persistent cough without a fever, but she's been taking ibuprofen for 7 days for pain, so that may have reduced the temperature. She and her mother have traveled for more than 4 hours to get to your clinic for care. The mother's demanding immediate attention for her daughter. And although in this case the dentist is willing to see the patient, the other staff members are worried that the patient might be infected with COVID-19 and want her to be tested first before agreeing to see her. So again, some of the same issues come up: duty to care, subordinating self-interest to the patient's interests. But something that's different about this case is what is the dentist obligations to his or her staff? How does the dentist weigh those obligations against obligations to the patient? Certainly some care, as we've mentioned, routine non-urgent care can probably be delayed and deferred for some time in order to reduce the risk to staff and to patients and family member. But is that the case in this scenario? What do you all think about whether this case should wait? Can care in this circumstance be delayed? Or does she need to be examined in order to make that decision, which would involve some risk? Can you reduce the number of staff involved to minimize the risk to staff? Can other steps be taken to reduce the risk? And again, could she be tested here? But if she's positive, wouldn't we still have an obligation to treat her? So at the end of the day here, there are competing obligations and duties both to the patient on the one hand, but also to the dental staff members. And the question is, who gets priority and how do we make that decision? And then finally, the case of a dentist who's considering reopening her practice, which has been closed for 3 months due to the COVID-19 pandemic. The closure has been extremely stressful financially for the dentist and her staff members, who she has been able to pay, but much less than their usual income. The dentist, however, is worried about the effect reopening her practice will have on the safety of her patients, of her staff, and herself. So here again, the one question is, what are the dentist's obligations to her staff and herself, both financially and in terms of safety? How does the dentist weigh those obligations against the obligations to the patient's interests, which are appropriate, timely care, but also safety? Are there steps that can be taken to reduce the risk all involved? So there probably are. You could ask screening questions of patients to see whether or not they have any risk factors for COVID. You could take temperatures of patients. You could engage in social distancing. You could schedule fewer patients in the office at any one time by spacing out appointments. You could remove items from the waiting room that might transmit the virus, such as toys for children or magazines. You could certainly have everybody involved wear personal protective equipment like masks and shields. You could reduce aerosolization by using different techniques. So rather than using ultrasonic scaling, you could use hand scaling, sort of the old-fashioned way, and having plenty of hand sanitizer available. But at the end of the day, giving the competing obligations and duties to patients and staff, this is a difficult set of decisions, a difficult set of circumstances, and it involves balancing and weighing the pros and cons of any given decision. So that's my presentation and the 4 cases. And I think now Dr. Cruz will introduce the 4 commentators that will comment on each of the 4 cases.
Okay, right now we have the participation of René Calvo, who will discuss the case number 1. René Calvo es un alumno de la especialidad de implantología y trabajará con el Dr. Carrese platicando sobre algunas consideraciones que él ha observado con relación a este caso. Please, Dr. Carrese, I introduce René Calvo. René, do you have some comments?
Yes. Hello, Dr. Joseph. First of all, I'd like to thank you, Dr. Joseph, for his or your invaluable participation on these seminars, because they are like a milestone to our community to keep ourselves getting better at this new subject, right? Because this coronavirus is a new thing for us, and I think for you too. So this thing is it's gonna be a breakthrough. I think the world is not just in the dental practice. The world is about to change, right? Because it can't be the way we used to do the things. I mean, the dental practice and stuff. But particularly in this case that you presented, the first one, I personally, I will try to make sure that the ailment, by ailment I mean the suffering of the patient, requires an intervention or a face-to-face visit. Because if it doesn't require a face-to-face visit, we can use the help of emerging technologies such as digital tools like Zoom or Cisco WebEx or whatever application you want to use to make sure we don't see the patient face-to-face, if you know what I mean, right? We can treat some of the patient sufferings, I think, via internet or digital or whatever you want to call it. But in this case, we diminish the risk of getting ourselves infected, right? Or put ourselves in risk, or the people who works in our clinic. Well, I mean, this is the first scenario that I would think. The second one is that the patient needs an intervention. So probably the most minimal intervention, I would think, to drain an abscess, gear ourselves up with all the face masks and stuff that it's coming up, and make an incision probably and drain the abscess and medicate the patient. That would be my second choice. Above all, I think the most important thing in this kind of particular cases is that avoid the use of a handpiece, or because if we use a handpiece, all the sprays are gonna, you know, fly all over ourselves and our hair and our assistants' hair and stuff. So I will, above all, I will try to avoid that. I'm sorry, but probably that will be my protocol. I mean, telemedicine, and if it doesn't, intervention. I'm sorry, make an incision, drain the abscess, medicate the patient, and ask the patient if he could like isolate himself for about 3, 4, or 5 days to make sure that he doesn't present these symptoms. And if he does, I will ask the patient to call me, to give me a call, so I can make sure that he receives the right treatment. I will make sure that he make this PCR tests, right, to coronavirus. And if it's negative, so we have to live some way, right? But to finish, I would like to comment and quote Darwin's Origins of Species is not the most intellectual, is not the most strongest that survives, is the most adaptable. We have to adapt to this new situation, all right? And to keep living, keep going on, because we have to keep living. Thank you, Dr. Joseph, and thank you toda la gente de la UNAM.
Well, I think that was a wonderful analysis of the case and very thoughtful. And if I understood what you were saying, it seems like you would, you know, there are some cases where you can try to use remote technology. You can try to make an assessment using a video, but there are certain cases where patients need to be seen and they need treatment. And I think I heard you saying that in this case, this child needs to have an examination and
Yes.
probably treatment.
Yes.
And then the question is, how can you do it most safely and reducing risk as much as possible? And you mentioned several steps that you can take in terms of equipment and personal protective equipment, as well as equipment you're using to do the procedure that would reduce the risk. You also very thoughtfully mentioned, what about after they leave your clinic? What about their ability to isolate from other family members, protect other family members, getting testing done, and thinking about our patients, not just when they stop thinking about them when they leave our clinic, but what about what happens next, and taking care of that and having a game plan. So I think that's very important that you mentioned. And I loved your comment from Darwin, this notion of adaptability. I'm a little older, so I think as you get older, it's a little harder to change and it's a little harder to adapt. But that's a really important point for all of us. And I think you're absolutely right. The world is going to be different. The world is different, and it will stay different. And it's going to be our ability to adapt to the changing circumstances that will determine how successful we are, most importantly for our patients and their family members. So
Yes.
Thank you for those wonderful comments.
Thank you.
So let's continue with the second case. Second case will be discussed by Dr. Lourdes Bravo. Doctora Lourdes Bravo, ella es doctora del Departamento de Implantología, de la especialidad de Implantología. Please, Dr. Lourdes Bravo, if you can turn on your microphone and your video. Okay, thank you. Please. Do you have any comment?
Yes, well, hello. Thank you, Dr. Carrese, for your extraordinary presentation. I think it's wonderful that we address bioethic issues, because sometimes we forget all about ethics. And I think it's a very important time to recome to ethics, right? Because of all what's happening that involves every aspect of our lives. So the second case involves a 65-year-old professor that wants to be reassigned because he's concerned with his health issues. So I think if it was my decision, and if I have, like you said, if I have other staff that could take on his work and do whatever he was doing, or if I can, and they are younger and they are healthier, I think I would try to reassign him to something else. Maybe not clinic, maybe he can do some desk work, maybe he can do some research, like for instance, a systematic review on the computer or in the library, not away from patients, if possible. If it's not possible, then I would try for him to see maybe less patients, or maybe the healthier patients, like small people or children or young people or people that we know that have had the virus, so that cannot infect him. So there are very many issues that we can try to do to minimize his risk. Of course, there's the risk for others, but as I'm saying, if the other doctors are healthier or younger, or the risk is less, as we know. And this doctor, well, not to tell him to go to his house, but he can still do a lot of good with all his knowledge, but he could do it from the desk maybe. And then if he had to see patients, I mean, I don't know why we're so concerned, because I know this new virus is very contagious, but we dentists have always been threatened with viruses. I mean, we should be, I don't know, we should be sure about our cross-infection control protocols that we have been always using. I mean, we don't know if the patient that comes in has AIDS. And the patient himself doesn't know he has AIDS. And we should be treating him like everyone else with our cross-infection protocols that we've always used. Maybe now we're a little more concerned because it's more contagious, but I think we should be sure of our cross-infection control protocols anyway, in the clinic and in our offices, everywhere. So that's what I would do.
Well, thank you very much again for wonderful comments, very thoughtful comments. I want to address first the point you made that you started with, and that is, you know, maybe we should, if we have enough staffing, try to adjust what he does and accommodate his requests to some extent, and not force him to work if there are alternatives. And we just had a presentation at our hospital last week in an ethics conference on the duty to care, and there were 3 different approaches to duty to care that were presented. One was very strict, very rigid, inflexible, said everyone has an absolute duty to care no matter what. This is what you signed up for. This is your professional obligation. It's the social contract, period. The next model of duty to care was it should be only voluntary. People should only have to put themselves in harm's way if they want to. And they pointed to the idea that if that's how we do it, maybe because they want to be doing it, they'll do better patient care. It'll be better care for patients. And maybe patients will trust the providers more because they know they want to be there. Of course, the problem with that is, what if you don't have enough volunteers? What if there aren't enough people who want to do the work? And the third model, I think, was more along the lines of what you were saying, and that is we should take into account the circumstances and the specific features of each patient provider and their circumstances. So we should make adjustments. And in a case like this, if there's a much higher risk and other people can step up who are at less risk, then maybe we should accommodate that. And there are other things that maybe they could do. I mean, at the same time, I agree with your point that HIV has been with us for decades, and that presented a problem for dentists and healthcare providers back in the 1980s and early 90s before there was treatment. It was very risky, and people's professional sense of duty to care was being tested. Were people willing to see patients who were infected? I think now that it's more of a chronic disease and it's not a death sentence, it makes it easier. But I think your point about universal precautions, I don't know the exact terminology you used, but cross-contamination or something you used. Could you say it again?
Cross-infection control protocol.
Cross-infection control,
But
not contamination.
Universal, yeah, universal is also for us. Universal,
Okay.
no,
So cross-infection control, and thinking about that, we should be doing that probably for everybody all the time. Although when we know somebody's infected, using equipment that doesn't cause the aerosolization are additional steps we can take. But so thank you. I think you made some excellent points, and it's something these are decisions that every system is dealing with right now. And I think dental practitioners, whether they're at a school or out in practice, have to be thinking about.
Yes, well, thank you again. Y gracias a todos los de la UNAM y a todos los demás personas que estén escuchando esta transmisión. Bye.
Gracias, doctora Lourdes. The next case will be discussed by Mario Rodríguez Tiscareño, who will discuss the case number 3. Mario Rodríguez Tiscareño es coordinador de la especialidad de implantología. Y bueno, Mario, por favor, si tienes algún comentario, please, let's start with your comments.
Good morning, doctor.
Good morning.
How are you? Okay, you want me to discuss the case?
Yes.
Okay, well,
Please.
yeah, it's interesting. It's not very common, these kind of cases in our clinic, because we deal with dental implants, but by coincidence, we just have a similar case about, we are treating a patient with Down syndrome. And what I was thinking in this scenery, well, I believe that in these times, that the ethic issue, it had become a very important issue because of the what it implies. So looking ahead of this case, well, it's the first thing that I would do is a questionnaire, to ask the patient the background, if he already have any kind of contact with COVID patients, or if he has for how long the symptoms. And I believe that the first thing that we have to do is to assess the degree of pain of the patient. Maybe we could treat it with pharmacological tooling, but we have to assess the degree of pain that the patient could refer. As Lourdes was discussing, one of our, for saying in some way, our weapons is to get very stick to our biosecurity protocols. If we use these protocols, we could handle maybe all the cases, but the thing here is that we don't have, maybe in some cases, this kind of training to handle with very strict protocols. We have to stick to very strict protocols in order to treat these kind of patients. As I was telling to you, that we have, by coincidence, a case like that. It's a patient with Down syndrome. He's about 38 years. And he attended maybe about 2 or 3 months with a pain abscess, and we have to extract one of the implants. It's an interesting case. But if that would happen at this time, maybe we have to make first questionnaire. That's what I would do. First a questionnaire. Second, assess the degree of pain, because maybe with a pharmacological treatment, we could solve the problem. And if not, if we have to see the patient, maybe we have to implement the routinary biosecurity protocol. the thing here is to make realize the staff that we have to stick to these kind of protocols, because maybe we are very relaxed, or time ago before we stop with our patients, the treatment of patients, we were very relaxed maybe with these kind of protocols. Right now we have to be very strict, wearing the mask, wearing the goggles, wearing all the armamentarium in order to make this kind of treatments. But definitely, if the patient has a pain episode, we have to handle it, and especially if the patient have an unbearable pain episode. So I don't know if this could be interesting to discuss it, but the thing here, I believe, is to talk with the staff, to be very strict with the biosecurity measures, to avoid this cross contamination, and to have a constant training for the staff in order to see these kind of patients.
So thank you very much for those comments. I really liked how you put this in terms of a sort of a stepwise approach, a sequence of things that would be done, starting with questionnaire screening to get more information about the patient and their risk. Then the assessment of the pain, like how much pain is the patient in, and is there an alternative here? Can they be treated with medication rather than having a physical procedure done? And then if you conclude from those first two steps that the patient really does need to be seen, they do need to be examined, maybe a procedure needs to be done, that you then engage in the biosecurity protocols, the safety protocols that would reduce the risk for everybody. And I think here part of the challenge is getting the staff on board, making sure the staff is educated, the staff is reassured that if we follow these procedures, the risk is reduced. I think the other thing that has to be communicated to the staff is the ethical and professional obligation that, we have an obligation to take care of this 4-year-old or this 17-year-old or this 82-year-old, that they have a problem. We are the providers. And if in our judgment, it needs to be taken care of now, then we should be willing to do that. If there are ways that it can be safely and responsibly treated some other way or delayed, then given the risk, then that's fine. But it requires honest and careful judgment to make those decisions. So thank you very much for your comments and your insights on this case. Appreciate it.
Thank you, Doctor. Thank you for your time and for your nice presentation. And just let me tell to my friends, gracias a todos los de la UNAM, excelente iniciativa de todos ustedes, y yo creo que ha sido todo un éxito y esperemos tener más eventos así. Thank you, Doctor, y gracias Luis Pablo, doctora Leyva y a todo el equipo. Muchísimas gracias.
Muchas gracias, Mario. For the last case presentation or discussion, we will have the participation of Ricardo Medellín Fuentes, who will discuss the case number 3. Ricardo is a professor from the orthodontic department. So, Ricardo, please, do you have any question, any comments about the case, please?
Yes, thank you very much, Dr. Cruz. First of all, I would like to thank you for this kind invitation and, of course, for the participation in the Dr. Carrese's participation. I think that the case number 4 is very interesting because it's the situation that we are living as a dentist. As you know, dentists, we work as an independent way, so all our staff members depend on us. Thus, reopen is a difficult decision, because probably you mentioned one of your points in your lecture was the moral distress, and I think it's a very interesting point because the dentist, if a dentist dies by coronavirus, normally, of course, we are the support of our families. So moral distress increases a lot. So talking about income, for example, is of course will not be the same as before. Even we decide reopen. So because patients don't want to go to the dentist because they are scared of getting infected. So that's why if we decide to reopen, we have to inform ourselves about the safety procedures and we must follow. So also I think that the day-to-day work will have to be modified. You will not be able to receive as many patients as you did before. So because talking about orthodontists, like is in my case, for example, on one of my busiest days, I could attend for about 20, 25 patients. So, and it wouldn't matter if the appointments overlapped. So now I spend more time probably cleaning between appointments, and everything is going to change. So we have to take more time between appointments in our agendas. I mean, we have to give more time between patient to patient, and of course, to take some time for getting our safety protocols. And we have to be sure that cleaning our surfaces in every patient, and of course take out some materials in our waiting rooms. So we could ask the patient come along to their appointments. I don't know if you, as a doctor, could recommend us or probably give us some suggestions or advices if we decide to reopen. Of course, that one thing I'm sure is everything is going to change.
No, I agree. I think I appreciate those comments. I appreciate your commentary on this case, which, as you point out, is dentists all over the world now are facing this. So are other other types of other aspects of the economy, businesses, restaurants. People are trying to make these decisions about how will we do business going forward, what needs to change in order for us to serve customers or clients or patients, but do so safely. You mentioned in your comments the moral distress that's involved because you have a responsibility to take care of your families and support your families, but also the staff who work with you. They rely on your income drives the whole operation. So that's a lot of responsibility and it's a lot of weight on your shoulders. Dr. Rene Calvo, commenting on the first case, talked about Darwin and the importance of adaptability. And I think several of your comments reinforce the point of adapting, that things will be different. You'll probably end up seeing fewer patients. You'll have to spend more time cleaning between appointments. You'll need to take steps to educate patients and inform them and probably reassure them that you are taking the necessary steps to minimize their risk and maximize their safety. And the bottom line is, at some point, everybody needs dental care. At some point, everybody needs health care. So it's not like this is something that can be completely ignored and just never dealt with again. People are going to need to come to see you. They're going to need to come to see me and get the dental and health care they need. And so it's a matter of us adjusting and adapting and bringing them along with us. But it still leaves a lot of difficult choices and decisions about when to do that, how soon to do it, and how exactly to do it.
Yeah, and the way.
So I appreciate your comments.
Thank you very much. Thank you for all of you. And a very nice presentation, Carrese.
Okay. Dr. Carrese, if you agree, maybe we can start with this question session.
Sure.
We have some questions from the audience from the Facebook. Jad Lopez, I think that what we're going to do is just I first read the question in Spanish, and then we will make a translation for you in English. Is that okay?
Yes, very good.
Nos pregunta, soy cirujano de 64 años y trabajo en una institución pública y me he negado a atender pacientes con COVID. Mis superiores me han comentado que no puedo negarme a atender a los pacientes con COVID. No tengo los insumos y no me han capacitado para el uso de eso. ¿Puedo pegarme a una objeción de conciencia? The translation will be something like, I am a 60 years old dentist and I work in a public institution. I have refused to take care of a patient with COVID. My superiors have told me that I cannot refuse to treat patients. So what's your opinion, Dr. Carrese?
Well, that's a bit difficult for me to comment on without knowing more information. I mean, I guess I would start by maybe, not that the person needs to give these answers, but if I were faced with that, if I were a supervisor and I was faced with that, I would ask some other questions like, what's the reason? What's the reason that you don't want to take care of the COVID patient? Are there factors about your own personal health, the health and risk factors for your family members that are playing a role in that decision? What are your own thoughts about your duty to serve and your duty to provide care to patients? What if every dentist said the same thing? What if no one was willing to take care of Ebola patients or HIV patients or patients with coronavirus? So I understand the concern. We all are exposed to the risk. I just spent 2 weeks over the past 6 weeks on an inpatient COVID unit that was not intensive care because I'm not an intensive care doctor, but you know, I was in the mask and the gown and the face shield, and it caused anxiety, it caused nervousness, but you know, at the end of the day, I felt I had a professional obligation. I think the other thing that we built into one of the earlier cases is because I'm a faculty member and I'm a professor, there are students who are looking at me and there are residents who are looking at me, and I'm a role model. So I feel like I have an additional responsibility to sort of step up to the plate under circumstances like this so that they see what I think should be done. But I think that it depends on the particular, as we've seen in some of the cases we presented, if there's additional factors like a disease or a drug that causes immunosuppression, then maybe it's a reasonable decision.
Okay, doctor, we have another question from the Facebook. ¿Cree que es un buen momento para abrir las clínicas dada la situación actual? The question is from Jad Lopez. Hello, doctor, I have a question. Do you think this is a good time to reopen dental practice, even the actual situation?
Let me just make sure, is this a good time to open the dental practices? Is that the question?
Yes.
Okay. Yeah, I think, you know, so I'm not a public health expert, but I think part of the answer to that question is talking with public health officials and getting their sense of whether or not they think it's safe to open. So just here in Maryland, in the state of Maryland, the governor just announced yesterday that he's opening up the state more. He's opening up restaurants and businesses and public gatherings with larger numbers. And a public health official at the Johns Hopkins School of Public Health publicly disagreed with him on that and said that he didn't think right now was the right time to make to go as far as the governor did in making those decisions. So I think I think this is a sort of city by city, town by town. Each jurisdiction has to assess its own sort of circumstances, what are their capabilities in terms of testing, in terms of contact tracing, and are they ready to reopen? I think reopening depends on all of those things, and one community, one jurisdiction is going to be different from another. So the bottom line is I can't answer that question for your community, but what I can say is if in order to decide for yourself, you have to get public health information and answer those other issues.
Okay, thank you for the answer. We have another question. Si tiene algún personal en el consultorio, es esencial proporcionar todo el equipo de protección personal en caso de que vea cualquier paciente que sea posible caso de COVID. The translation will be something like, if you have some staff at your dental practice, it's essential to provide all the PPE that in case that you are trying to treat a possible case with possible COVID case.
So could you say that one more time? I'm sorry.
Okay. If you have some staff at your practice, it's essential to provide all the personal protective equipment in the case that you have see any patient that is possibly infected with COVID.
I'm sorry. Yes, thank you for repeating. Yeah, I mean, I feel like, again, I'm not, I would say yes. I mean, I think that's the expectation we have at the hospital. There's been examples throughout the United States of nurses and doctors not having enough equipment in emergency departments, and you know, healthcare workers have been quite vocal here that if you're gonna, we're happy to do our responsibility. We're happy to fulfill our professional duties and obligations and see patients, even if it means putting ourselves in harm's way. But your part of the bargain is providing us with the equipment we need to stay safe, because, you know, we're the frontline workers. What happens if we get sick and if we die? What are you going to do then? And I think it's the same thing with dental providers. You're willing to step up to the plate and see people. Your staff is willing to participate, but I think part of that bargain is providing them with equipment that is known to be helpful in reducing risk of transmission. And I think I think that if it's, you know, it would be, if it's at all feasible, it should be provided. I guess the question would be, maybe there are some towns or you know, communities where there aren't the resources to do that. But I think then that's where, at least in the United States, I would think the government has a responsibility, whether it's at the state level, the federal level, to help out and provide that equipment for healthcare professionals, including the dentists and their staff.
Doctor, we have another question. The question is from Doctora Carolina Higashida. ¿Cree que hay similitudes entre lo que vivimos hoy con el COVID y lo que vivimos hace un par de décadas con el VIH? ¿Podría esta relación proyectarse en lo que sucederá en un futuro cercano con el COVID y el tratamiento médico dental? The question is, do you think that there are maybe similarities between what we are living today with the COVID and what we lived a couple decades ago with HIV? That could, could this relation be projected in what will happen in the near future with COVID and medical or dental treatment?
I think there are parallels, and I think there are important lessons to learn. Certainly at the beginning of HIV, there was a lot of stigma and bias against the populations that were considered to be the primary subjects, patients who had HIV. So there was racial bias and stigma and group bias. There was a very high death rate from people who contracted the virus. So that part is also similar. It took a very long time to develop testing and medications that have turned it into essentially a chronic disease. So that part of it is encouraging and reassuring that eventually, with all the technology and resources we have in the world, I think we can feel pretty hopeful that we will get effective medications. Hopefully we will get an effective vaccine, although unless I'm mistaken, there's currently no vaccine for HIV. So the idea that, you know, we'll have a vaccine in a few months is we all can hope for that, but there's no guarantee that that's going to happen. And even if we do get a successful vaccine for COVID, it may take a few tries for that to work out. So that could be, the most hopeful projection is maybe a year or so, but it may take a lot longer. So I do think there are some parallels. I think, one thing we learned from HIV, that at least in the United States, there was a very delayed response from the federal government. And the resources that were necessary to fund research, to fund innovative treatments was very delayed, and a lot of people died because of that. And, I think we would want to avoid making similar mistakes with coronavirus.
Okay. Doctor, we have more than questions and comments about, congratulations about your lecture. Lupita Rodriguez said, what Dr. Lourdes comment about case 2, it's truly wise. We as dental practitioners should be confident about giving attention to dental patients despite these unusual circumstances, because we have been trained and taught to see out and treat every patient as a potentially contagious. In everyday dental practice, we are exposed to several infections. We have another comment that we will be able to work as far as our possibility allow us, always seeking our safety before any procedure. There are flow diagrams to make decisions based on what the patient presents or refers. I don't think that after everything we could return to provide attention as we used to. So there are comments like that, and we have worked with another questions, doctor, and the first one will be, what do you think is the most important ethics and professionalism issue for dental practitioners related to the COVID-19 pandemic?
Well, that's difficult because I think there are as I mentioned, there are many issues, but I think, front and center is this notion of duty to care, our obligation to serve, our obligation to take care of patients. I do believe that is something that we've all signed up for. I think it's a cornerstone of professionalism. And professionalism, we have a dental profession, we have a healthcare profession because society allows us to exist. And they give us a lot of autonomy and a lot of privilege. But in exchange for that, they expect us to adhere to core principles of professionalism and ethics. And one of those core principles is putting the patients first, putting society first. And that means sometimes we have to, like soldiers in an army, we have to put the bigger objective, the public's interest ahead of our own. I think we want to do that as safely as we can. We want to be flexible and consider where there might need to be accommodations or exceptions. We need to take into consideration our obligation to benefit patients and protect them from harm, and striking the right balance there. But I think a number of the issues that we encounter here are coming back to that core responsibility, professional and ethical responsibility of our duty to serve. And I think if the public sees us shying away from that and stepping away from that, we risk undermining the public trust and their willingness to give us the autonomy, the privilege, and the respect that we think we deserve.
Thank you, Dr. Carrese. The next questions will be, we have just talked about dental practitioner, but what about dental practice? What do you think is the most important ethics and professionalism issue for dental practice?
Well, I think, I guess I mean, I'm not obviously as familiar with dental practice as I am with medical practice, but I think for me, I think it's given the cases that we had today and the comments that were made by the student and the 3 professors, I think that the duty to care, the duty to serve is still a major issue. One of the questions that came up earlier was an older dentist who decided that they didn't want to see a patient with COVID. So I think this is an issue we're all wrestling with, whether we're in dental care or nursing or social work, meeting our patients, taking care of our patients, despite putting ourselves in harm's way. So I think that's certainly not the only issue, but I still consider it to be a central point of tension for dentists as well as other healthcare professionals.
Okay, doctor. One more question. If you could change one thing about how the COVID pandemic has affected dental care, what would it be?
Well, if I could change one thing, it would be that it never happened. That would be, but I obviously don't have that kind of power or control. I guess to some extent, the answer to that question depends on where you're living and what the resources are. I mean, I think we've certainly seen in the United States that there are communities that have been harder hit and haven't had the resources when they need them to provide optimal care, excellent care, standard care. So I would say if there are communities in Mexico or across Latin America where there's a struggle to find the necessary resources, whether it's personal protective equipment or testing or contact tracing to have this go as well as it could, then that would be one thing to change. Is, what are the local governments, the state governments, the federal governments, what more could they be doing to help out specific communities address the problem? Can't go away. It's here. It's going to be here for a while. We don't know what it's going to do in the future. And the one thing we can change is how we approach it and the resources we bring to bear. So I guess that's what I would say, doing a better job of maximizing resources so we can have the best response possible.
We have 2 questions left, and the first one will be, are there any important ethics and professionalism issue for dental practitioners or dental practice that weren't included in the presentation that should be mentioned?
Well, actually, so you and I wrote that question, and I was thinking that would be a question we'd put to the audience. Like, was there anything that they heard or that they were thinking about that we didn't cover? Because all of the items that I presented are the ones that we could think of. So I'm wondering if anybody who's been listening, if there were issues that they felt like should have been covered or should have been mentioned that they think are important but weren't included in our framework or in the cases that we discussed. But off the top of my head, I think we've covered a pretty good number of the important issues.
Okay, and finally, do you think there will be a permanent change related to how we think about ethics and professionalism issue in dental care and of this pandemic, COVID-19?
Yes, I think as we've discussed already, as a number of the commentators have mentioned, that change is a part of our future because of this. How we go about doing dental practice, medical practice, how we go about teaching our students, whether they're in grade school or high school or college, or the healthcare profession schools like dental school, nursing, social work, medicine, that's all going to change to some extent. How we go about doing business will change. So I think it's absolutely the case that coronavirus has changed how we will do business. And as a result, it's changed how we think about sort of the ethics and the professionalism. And one way that will change is, I think, going forward, at least for some period of time, we'll continue to live with this tension between the considerations from the public health perspective and safety of the community, and that being in tension with what we think we should be doing for any given individual patient. And our usual approach to individual patients at times will need to be subordinated to or give way to public health considerations. And so I think that's maybe the biggest change going forward, is that balance between individual patients and the public health, and how that changes how we do care for individual patients and how we do education.
Dr. Carrese, it was an amazing lecture. And we have, sorry. Okay, it was an amazing lecture, and we want to thank you at the name of School of Dentistry of National Autonomous University of Mexico would like to thank you for taking part of this lecture of COVID-19, your talk on ethics concerns and considerations for dentists during this COVID pandemic is one of the most interesting topics of this forum. It was an honor for our school to have you as one of the speakers. We believe that the knowledge that you have shared will help our students to have a better understanding of the ethics issue. We hope to have you as a speaker at the 2021 Oral Public Health Meeting at the UNAM. Thank you, Dr. Carrese.
Thank you very much, Dr. Cruz. I appreciate it. I thank you, the four commentators, your dean, and the audience for participating. It was a great pleasure. Thank you very much.
So I will give lecture for the Constance. Universidad Nacional Autónoma de México y la Facultad de Odontología agradece o otorga la presente constancia al Dr. Joseph Carrese por su participación académica en el tema Contexto bioético de la atención dental en tiempos de COVID-19. En el ciclo de conferencias COVID-19, atentamente por mi raza hablará el espíritu. Ciudad Universitaria, 12 de junio del 2020, firma el calce nuestra directora Elba, Rosa, Leyva, Huerta, directora de la Facultad de Odontología, quien se despide y le mando un saludo. Muchísimas gracias al auditorio que nos sigue en Facebook. Cerramos la transmisión en Facebook. En un momento nos conectamos otra vez. Le agradecemos al Dr. Carrese la presentación. Thank you, Dr. Carrese. See you later.
Gracias. Thank you.